Question 1. In managing a trauma patient with multiple injuries, you arrive on scene to find a patient with a severe laceration on their arm, a possible broken leg, and signs of respiratory distress. You need to assess and prioritize care. Based on trauma management principles, which of the following steps should you take first? A. Apply a tourniquet to control the bleeding from the arm. B. Administer high-flow oxygen and assess the patient's respiratory status. C. Immobilize the patient's leg fracture. D. Start an intravenous Romanin for fluid resuscitation. Answer. B. Administer high-flow oxygen and assess the patient's respiratory status. Explanation. When managing a trauma patient, the primary assessment should follow the ACTS airway breathing circulation to ensure life-threatening conditions are addressed first. Given that the patient is showing signs of respiratory distress, it is critical to address the airway and breathing before controlling bleeding or immobilizing fractures. Administering high-flow oxygen and the respiratory status are the first steps to stabilize the patient's breathing and oxygenation levels. Once the airway and breathing are secured, you can proceed to manage the circulation, bleeding control, immobilize fractures, and provide Roman access for fluid resuscitation if necessary. Question 2. A 62-year-old male patient presents with chest pain, sweating, and shortness of breath. His medical history includes hypertension, diabetes, and hyperlipidemia. The patient appears anxious and is clutching his chest. What is the most appropriate initial management for this patient based on the potential for a myocardial infarction? A. Administer aspirin and nitroglycerin, ensuring blood pressure is monitored. B. Provide oxygen and prepare for transport without administering any medications. C. Administer morphine for pain relief and perform a 12-lead ECG. D. Begin CPR immediately and prepare for defibrillation. Answer A. Administer aspirin and nitroglycerin, ensuring blood pressure is monitored. Explanation. Given the patient's symptoms of chest pain, sweating, and shortness of breath, he is likely experiencing a myocardial infarction. The initial management of a suspected MI involves administering aspirin to inhibit platelet aggregation and reduce the likelihood of further clot formation. Nitroglycerin can be used to relieve chest pain by coronary arteries, but it should only be administered if the patient's blood pressure allows, typically systolic LP9 mHg. Monitoring blood pressure is essential as nitroglycerin can lower it. A 12-lead ECG should also be performed to assess the severity of the MI and guide further treatment. Administering morphine is not the first line of treatment, as nitroglycerin should be used earlier. CPR and defibrillation are indicated. Cardiac arrest, not for. It's stable. My presentation. Question 3, scenario-based. Mr. Williams, a 45-year-old male, was involved in a motor vehicle collision. He is conscious but appears to have a deformed and painful leg. Upon assessment, you observe the leg is angulated and swollen, but there is no significant external bleeding. He is also complaining of difficulty breathing. What is the most appropriate course of action for this patient? A. Immobilize the leg and transport immediately, providing supplemental oxygen. B. Apply a splint to the leg and monitor the airway while transporting to the hospital. C. Begin CPR and prepare for advanced airway management. D. Focus on controlling the leg injury before addressing his respiratory distress. Answer A. Immobilize the leg and transport immediately, providing supplemental oxygen. Explanation. In this scenario, the patient's most concerning issue is likely his respiratory distress, and given the presence of a significant leg injury, possible fracture, it is important to prioritize interventions that stabilize both his airway and circulatory status. First, administer supplemental oxygen to address any potential hypoxia due to difficult breathing. Immobilize the leg to prevent further injury or discomfort during transport. The leg injury, while important, should not delay addressing the patient's airway and oxygenation needs. Begin transport to the hospital while continuously monitoring his condition. CPR and advanced airway management, choice C, are not indicated unless the patient becomes unresponsive or stops breathing. Focusing only on the leg injury, choice D, addressing the respiratory distress would be inappropriate as airway and breathing are more critical. Question 4. A 72-year-old female patient presents with confusion, difficulty breathing, and swelling in her legs. Her medical history includes chronic obstructive pulmonary disease, COPD, hypertension, and diabetes. Upon examination, you find bilateral pedal edema, an increased respiratory rate, and crackles upon auscultation of the lungs. She appears to be in moderate respiratory distress. What is the most likely diagnosis and the management strategy? A. Pneumonia. Administer broad-spectrum antibiotics and prepare for transport. B. Congestive heart failure. E. Provide oxygen therapy. Administer diuretics and prepare for transport. C. Myocardial infarction. Administer aspirin and nitroglycerin, ensuring blood pressure is monitored. D. Acute asthma exacerbation. Administer albuterol and provide supplemental oxygen. Answer: B. Congestive heart failure. C. Provide oxygen therapy. Administer diuretics and prepare for transport. Explanation: the patient's symptoms of confusion, difficulty breathing, bilateral pedal edema, and crackles on lung auscultation suggest congestive heart failure. E8. CTEPH occurs when the heart is unable to pump blood efficiently, leading to fluid backup in the lungs, pulmonary edema, and peripheral edema. Initial management for CHF involves providing oxygen therapy to improve oxygenation and administering diuretics, e.g. furosemide, to reduce fluid overload. Pneumonia is less likely in this scenario due to the absence of fever and productive cough. Myocardial infarction, C, is because the patient's symptoms are more consistent with heart failure than with acute chest pain or typical MI signs. Acute asthma exacerbation, D, is also less likely, given the absence of wheezing and the patient's medical history of COPD rather than asthma. Question 5. A 4-year-old child is brought in by parents who report that the child accidentally ingested a bottle of household bleach. The child is crying and drooling, and there is visible irritation around the mouth. The child's airway is clear and breathing is unlabored, but the parents mention the child has been complaining of burning sensation in their throat. What should be the first step in managing this poisoning situation? A. Administer activated charcoal to neutralize the bleach. B. Encourage the child to drink water or milk to dilute the bleach. C. Immediately transport the child to the hospital without any oral intake. D. Perform rapid assessment of the child's airway and initiate CPR if necessary. Answer: C. Immediately transport the child to the hospital without any oral intake. Explanation: in cases of ingestion of caustic substances like bleach, the primary concern is ensuring the airway is protected and preventing further injury to the gastrointestinal tract. Administering water or milk, B, is not recommended as it may worsen the injury by promoting further absorption of the substance. Activated charcoal, A, is not effective for caustic poisoning and could delay transport. The best course of action is to immediately transport the child to the hospital, C, where they can receive appropriate medical care, such as endoscopy, to evaluate the damage and manage the ingestion. Performing CPR, D, would only be necessary if the child stopped breathing or became unresponsive, which is not indicated at this time. Question 6. A 32-year-old female patient presents with a sudden onset of severe chest pain radiating to her left arm, nausea and diaphoresis. She has a history of smoking and hypertension but has no prior history of heart disease. Her vital signs show an elevated heart rate and blood pressure. The patient is conscious but appears anxious and in pain. What is the best course of action for managing this patient in the pre-hospital setting? A. Administer nitroglycerin, monitor vital signs, and prepare for immediate transport to a cardiac facility. B. Administer morphine for pain relief and monitor vital signs closely. C. Place the patient in a supine position and administer high-flow oxygen. D. Obtain a 12-lead ECK and administer aspirin while preparing for transport. Answer: D. Obtain a 12-lead ECK and administer aspirin while preparing for transport. Explanation: the patient's presentation is highly suggestive of an acute myocardial infarction, MI, which requires prompt assessment and intervention. The best initial management includes obtaining a 12-lead ECK to assess for any segment changes or other abnormalities indicative of an MI. Aspirin should be administered to inhibit platelet aggregation and reduce the formation of blood clots. Nitroglycerin may be given if the patient's blood pressure is adequate, but aspirin is the priority before nitroglycerin. Morphine, B, can be used for pain relief in a hospital setting but is not a first-line treatment in the pre-hospital phase for an MI. A supine position, C, is generally not recommended for chest pain patients as a more comfortable position, semi-recline, may be preferable. Question 7. A 56-year-old male patient with a history of type 2 diabetes presents with confusion, excessive thirst, and frequent urination. His blood glucose is measured at 400 ppmdL and he has a fruity odor on his breath. Upon further assessment, you observe rapid, shallow breathing and signs of dehydration. What is the most likely diagnosis and how should you manage the patient? A. Diabetic ketoacidosis DKA. Administer insulin fluids and prepare for transport. B. Hypoglycemic hyperosmolar. A. Chest. Administer insulin fluids and prepare for transport. C. Acute myocardial infarction. Administer aspirin, nitroglycerin, and transport immediately. D. Stroke. Administer glucose and transport immediately for AECAM. Answer A. Diabetic ketoacidosis DKA. Administer insulin fluids and prepare for transport. Explanation. The patient's signs and symptoms: confusion, excessive thirst, frequent urination, fruity breath, rapid breathing, are most consistent with diabetic ketoacidosis DKA, a life-threatening complication of diabetes that occurs when insulin levels are insufficient and the body starts breaking down fat for energy, producing ketones. The fruity odor on the breath is due to the presence of acetone, a type of ketone, and management of DKA involves administering fluids to rehydrate the patient and insulin to reduce the elevated blood glucose levels. Hypoglycemic hyperosmolar, HSB, also involves high blood glucose levels, but typically lacks the ketone production seen in DKA. An acute myocardial infarction, C, would involve chest pain, not confusion, and fruity breath. Stroke, D, would present with neurological deficits, not the symptoms of dehydration and hypoglycemia. Question 8. A 22-year-old male is brought to the emergency department after a motorcycle accident. He is unconscious and has a DS score of 8. He is breathing spontaneously but has a rapid and shallow respiratory pattern. His blood pressure is low and there is a large contusion to his abdomen. You suspect a possible internal hemorrhage. What is the most appropriate course of action in this situation? A. Administer high-flow oxygen. Place a pelvic binder and transport to a trauma center. B. Apply a cervical collar, immobilize on a backboard, and prepare for immediate intubation. C. Focus on controlling external bleeding and provide pain management. D. Begin CPR and prepare for advanced airway management. Answer A. Administer high-flow oxygen. Place a pelvic binder and transport to a trauma center. Explanation. The patient's OGCS score indicates a potentially significant head injury, but his primary issue is the possibility of internal hemorrhage, particularly given the abdominal contusion and signs of shock, low blood pressure. Administering high-flow oxygen is essential to support oxygenation, and a pelvic binder should be applied to stabilize any potential pelvic fractures that may be contributing to internal bleeding. Transport to a trauma center should be prioritized to allow for further diagnostic evaluation and intervention. While immobilizing the patient is important, the focus should be on stabilizing his circulatory status and preventing further blood loss rather than intubation at this stage. External bleeding control, C, and pain management are important, but not the immediate priority. CPR, D, is not needed unless the patient becomes unresponsive or arrests. Question 9. A 29-year-old female presents to the emergency room complaining of sudden dizziness, weakness on one side of her body, and difficulty speaking. She has a history of oral contraceptive use and smoking. On examination, she has right-sided hemiparesis and slurred speech. What is the most likely diagnosis and how should you proceed with treatment? A. Stroke. Immediately administer thrombolytics and prepare for transport to a stroke center. B. Transient ischemic attack tier. Administer aspirin and arrange for follow-up. C. Seizure. Administer lorazepam and monitor closely. D. Hypoglycemia. Administer glucose and monitor for improvement. Answer A. Stroke. Immediately administer thrombolytics and prepare for transport to a stroke center. Explanation. The patient's symptoms of dizziness, weakness on one side of her body, and difficulty speaking are indicative of a stroke, most likely an ischemic stroke, given the presence of risk factors such as smoking and oral contraceptive use. The immediate management of a stroke A involves administering thrombolytics if the patient is within appropriate time window to dissolve the clot obstructing the cerebral circulation. The patient should also be prepared for transport to a stroke center for advanced care. A transient ischemic attack tier B is a brief episode of neurological dysfunction but does not cause permanent symptoms like a stroke. Seizures C typically present with involuntary movements or altered consciousness, which this patient does not exhibit. Hypoglycemia D cause weakness and confusion, but it does not explain the focal neurological deficits or slurred speech seen in this case. Question 10. A 65-year-old male with a history of hypertension and smoking presents to the emergency department with severe chest pain radiating to his left arm and jaw. He is diaphoretic and his vital signs show tachycardia, elevated blood pressure, and a low oxygen saturation. The patient is anxious and his pain is unrelieved by rest. What is the most likely diagnosis and what is the next best step in management? A. Acute myocardial infarction. Administer aspirin, nitroglycerin, and prepare for immediate transport to a cardiac catheterization lab. B. Pulmonary embolism. P. Administer heparin, oxygen therapy, and prepare for a pulmonary angiogram. C. Aortic dissection. Administer antihypertensive medications, initiate Roman fluids, and prepare for transport to a surgical center. D. Acute pancreatitis. Administer pain management, Roman fluids, and prepare for imaging studies. Answer A. Acute myocardial infarction. Administer aspirin, nitroglycerin, and prepare for immediate transport to a cardiac catheterization lab. Explanation: the patient's presentation of severe chest pain radiating to the left arm and jaw associated with tachycardia, hypertension, and diaphoresis strongly suggests acute myocardial infarction. The first-line treatment for suspected MI includes administering aspirin, reduce platelet aggregation, nitroglycerin to relieve chest pain and reduce myocardial oxygen demand, and preparing for transport to a facility capable of performing a cardiac catheterization. Pulmonary embolism (PB) may present with chest pain, but typically causes shortness of breath, tachypnea, and a risk factor like deep vein thrombosis. Aortic dissection (C) presents with tearing chest pain and is associated with aortic rupture, but this patient's presentation is more consistent with MI. Acute pancreatitis (D) usually presents with epigastric pain and would not typically cause the left-sided chest pain radiating to the arm and jaw. Question 11. A 25-year-old male presents with a fever, productive cough, and pleuritic chest pain. He reports a history of travel to South America 2 weeks ago. On examination, his lung sounds are clear and his vital signs are stable. A chest X-ray shows a localized opacity in the right lower lung field. What is the most likely diagnosis and what is the initial management approach? A. Tuberculosis (TB). Initiate a T regimen with rifampin, isoniazid, and pyrazinamide and isolate the patient. B. Pneumonia. Initiate broad-spectrum antibiotics and monitor for improvement. C. Pulmonary embolism. P. Administer heparin and order a pulmonary angiogram. D. Lung abscess. Initiate antibiotics and consider surgical drainage if symptoms persist. Answer B. Pneumonia. Initiate broad-spectrum antibiotics and monitor for improvement. Explanation: the patient's fever, productive cough, pleuritic chest pain, and the finding of localized opacity on the chest X-ray suggest pneumonia, particularly bacterial pneumonia. The patient's travel history and the absence of significant respiratory distress point more toward common bacterial etiology. The first step in treatment is broad-spectrum antibiotics while awaiting sputum cultures. Tuberculosis can cause cough and fever but would more commonly present with longer duration of symptoms and other signs like night sweats, weight loss, or hemoptysis. Pulmonary embolism (C) presents with sudden onset chest pain, dyspnea, and risk factors such as deep vein thrombosis, which are not indicated in this case. Lung abscess (D) typically presents with persistent foul-smelling sputum and more chronic course, often seen in patients with aspiration pneumonia. Question 12. A 30-year-old female presents with sudden onset severe headache, nausea, and vomiting. She reports a history of chronic headaches but states this headache is unlike any she has had before. On examination, her blood pressure is elevated and she has photophobia and neck stiffness. A K of the head reveals no evidence of hemorrhage, but a lumbar puncture shows increased opening pressure and cerebrospinal fluid (CSF) analysis consistent with meningitis. What is the most likely diagnosis and what is the next step in management? A. Migraine headache. Administer sumatriptan and provide supportive care. B. Subarachnoid hemorrhage. Prepare for emergency neurosurgical consultation. C. Bacterial meningitis. Initiate broad-spectrum antibiotics and consider corticosteroids. D. Viral meningitis. Initiate antiviral therapy and monitor closely. Answer C. Bacterial meningitis. Initiate broad-spectrum antibiotics and consider corticosteroids. Explanation: the patient's presentation of sudden onset severe headache, photophobia, neck stiffness, and signs of increased intracranial pressure e.g. vomiting along with CSF findings suggest bacterial meningitis, life-threatening infection that requires immediate intervention. The next best step is to initiate broad-spectrum antibiotic. Cover the most common bacterial pathogens while awaiting culture results. Corticosteroids may be considered in the setting of bacterial meningitis to reduce inflammation and prevent neurologic complications. Subarachnoid hemorrhage B could present with severe headache, but the CT scan would likely reveal blood in the subarachnoid space, which is absent here. Viral meningitis D may present similarly, but typically has milder course and entova. Therapy is not indicated for most viral causes of meningitis. Question 13. A 45-year-old male with a history of alcohol use disorder presents with confusion, tremors, and diaphoresis. He has a history of detoxification multiple times. His vital signs show tachycardia and elevated blood pressure. On examination, he appears anxious, with tremors in both hands, and his reflexes are hyperactive. What is the most likely diagnosis, and how should this patient be managed? A. Alcohol withdrawal delirium, delirium tremens. Administer benzodiazepines, fluids, and electrolytes. B. Acute alcohol intoxication. Administer intravenous fluids and monitor for respiratory depression. C. Wernicke's encephalopathy. Administer thiamine and glucose. D. Sepsis. Initiate broad-spectrum antibiotics and prepare for intensive care unit admission. Answer A. Alcohol withdrawal delirium, delirium tremens. Administer benzodiazepines, fluids, and electrolytes. Explanation: the patient's confusion, tremors, diaphoresis, and hyperactive reflexes, combined with a history of alcohol use disorder and multiple detoxifications, are consistent with alcohol withdrawal delirium, delirium tremens. The next step in treatment is to administer benzodiazepines e.g. lorazepam to withdraw symptoms along with fluids and electrolyte correction. Acute alcohol intoxication B would present with confusion and sedation, not tremors or hyperreflexia. Wernicke's encephalopathy C is characterized by confusion, ataxia, and ophthalmoplegia, typically due to thiamine deficiency and chronic alcohol use. Sepsis D would present with signs of infection, such as fever and signs of organ dysfunction, which are not observed here. Question 14. A 40-year-old female with a history of hypothyroidism presents with fatigue, weight gain, and dry skin. She reports feeling cold all the time and has noticed her hair thinning. On examination, she has a slow heart rate, brittle nails, and a coarse voice. Her lab results show elevated thyroid-stimulating hormone T8 and low free thyroxine. What is the most appropriate treatment for this condition? A. Levothyroxine. Initiate a low dose and titrate upward based on thyroid function tests. B. Propylthiouracil. Start with a low dose and monitor liver function closely. C. Methimazole. Initiate therapy and monitor for signs of agranulocytosis. D. Radioactive iodine therapy. Monitor for hypothyroidism after treatment. Answer A. Levothyroxine. Initiate a low dose and titrate upward based on thyroid function tests. Explanation: the patient's symptoms of fatigue, weight gain, dry skin, and cold intolerance, along with laboratory findings of elevated TH and low FreeT, indicate primary hypothyroidism. The treatment of choice for hypothyroidism is levothyroxine, synthetic form of thyroid hormone. The dose should be initiated low and titrate upward based on follow-up thyroid function tests to avoid exacerbating cardiovascular issues such as arrhythmias. Propylthiouracil B and methimazole C are used to treat hypothyroidism, not hypothyroidism. Radioactive iodine therapy D is used for the treatment of hypothyroidism or thyroid cancer, not for hypothyroidism. Question 15. A 50-year-old male with a history of chronic back pain presents with acute low back pain after lifting a heavy object. He reports pain radiating down his right leg associated with numbness and tingling. On examination, he has decreased sensation along the L-dermatome and diminished reflexes in the right ankle. What is the most likely diagnosis and what is the initial management? A. Lumbar disc herniation. Recommend rest, NSAIDs, and physical therapy. B. Spinal cord compression. Initiate corticosteroids and prepare for urgent MRI. C. Cauda equina syndrome. Initiate high-dose steroids and prepare for immediate surgical consultation. D. Sciatica. Recommend rest, apply heat, and prescribe muscle relaxants. Answer A. Lumbar disc herniation. Recommend rest, NSAIDs, and physical therapy. Explanation: the patient's acute low back pain with radiating leg pain, numbness, and tingling suggests lumbar disc herniation, common cause of radiculopathy. The most likely affected nerve root is LL. Given the patient's sensory changes and diminished reflexes, initial management includes rest, non-steroidal anti-inflammatory drugs, NSAIDs for pain relief. Physical therapy. Spinal cord compression B would typically present with more severe neurological deficits, including bladder or bowel dysfunction, which are not present here. Cauda equina syndrome C is medical emergency but is associated with severe symptoms including loss of bowel or bladder control and would require surgical consultation. Sciatica D typically presents as pain without significant neurological deficits and is less given the patient's findings. Question 16. A 28-year-old pregnant woman in her third trimester presents with hypertension, BP 106/100, edema, and proteinuria. She complains of a severe headache and visual changes. Laboratory tests reveal elevated liver enzymes, low platelet count, and a creatinine of 1.2 mg/dl. What is the most likely diagnosis and what is the appropriate treatment? A. Preeclampsia. Administer antihypertensive medications and prepare for early delivery if necessary. B. Eclampsia. Administer magnesium sulfate for seizure prevention and initiate delivery. C. Acute fatty liver of pregnancy. Manage with supportive care and monitor liver function. D. Chronic hypertension. Continue antihypertensive medications and monitor closely. Answer: B. Eclampsia. Administer magnesium sulfate for seizure prevention and initiate delivery. Explanation: the patient presents with signs of preeclampsia, hypertension, proteinuria, edema, along with elevated liver enzymes, low platelets, and renal involvement, all of which suggest progression to eclampsia. Eclampsia is characterized by preeclampsia with the onset of seizures and requires immediate management with magnesium sulfate for seizure prevention and urgent delivery of the baby. Preeclampsia would not present with seizures, and acute fatty liver of pregnancy C usually presents with right upper quadrant pain, nausea, vomiting, and jaundice, not visual disturbances or severe headache. Chronic hypertension D does not typically cause the severe systemic symptoms seen in this patient. Question 17. A 55-year-old male with a history of hypertension and hyperlipidemia presents with severe chest pain radiating to his back, shortness of breath, and nausea. His blood pressure is 100/100 Hg, and he has a weak, delayed femoral pulse. The chest X-ray reveals a widened mediastinum. What is the most likely diagnosis, and what is the next step in management? A. Acute myocardial infarction. Administer aspirin, nitroglycerin, and prepare for cardiac catheterization. B. Aortic dissection. Initiate antihypertensive therapy and prepare for urgent surgery. C. Pulmonary embolism. Administer heparin and prepare for a pulmonary angiogram. D. Acute pancreatitis. Initiate Romanuids and monitor for complications. Answer: B. Aortic dissection. Initiate antihypertensive therapy and prepare for urgent surgery. Explanation: the patient's presentation of severe chest pain radiating to the back along with a widened mediastinum on chest X-ray suggests aortic dissection. The first step in management is to lower blood pressure rapidly with antihypertensive medications to reduce the stress on the aortic wall and prevent rupture. Surgical intervention is necessary depending on the location and extent of the dissection. Acute myocardial infarction, they could present with chest pain, but a widened mediastinum is more characteristic of aortic dissection. Pulmonary embolism C presents with sudden onset chest pain and shortness of breath, but does not typically cause a widened mediastinum. Acute pancreatitis D presents with abdominal pain, nausea, and vomiting, not chest pain. Question 18. A 60-year-old male with a history of diabetes mellitus and coronary artery disease presents with a sudden onset of right-sided weakness, slurred speech, and difficulty swallowing. His vital signs are stable, and his neurological exam reveals right-sided hemiparesis and dysarthria. A non-contrast CT scan of the head is negative for hemorrhage. What is the most likely diagnosis, and what is the next best step in management? A. Stroke. Administer thrombolytics within 4.5 hours of symptom onset. B. Transient ischemic attack. T. Monitor closely and initiate antiplatelet therapy. C. Bell's palsy. Initiate corticosteroid therapy and provide supportive care. D. Hypoglycemia. Administer glucose and reassess. Answer A. Stroke. Administer thrombolytics within 4.5 hours of symptom onset. Explanation: the patient presents with sudden onset right-sided weakness and dysarthria, suggesting an acute ischemic stroke. Since the non-contrast CT scan is negative for hemorrhage, thrombolytic therapy G. Alteplase is indicated within 4.5 hours of symptom onset. This treatment can help dissolve the clot and restore blood flow to the affected brain region. A transient ischemic attack B would present with symptoms that resolve within 24 hours and typically do not require thrombolytics. Bell's palsy C affects facial muscles and does not cause hemiparesis or dysarthria. Hypoglycemia D could cause confusion and weakness. This patient's presentation with focal neurological deficits is more consistent with stroke. Question 19. A 42-year-old female presents with generalized muscle weakness, fatigue, and difficulty swallowing. She reports that her symptoms worsen at the end of the day. Her physical examination reveals ptosis and a decreased gag reflex. Her reflexes are normal, and she has no sensory deficits. What is the most likely diagnosis, and what is the diagnostic test of choice? A multiple sclerosis. Order and MRI of the brain and spinal cord. B. Myasthenia gravis. Order an acetylcholine receptor antibody test. C. Amyotrophic lateral sclerosis. Order electromyography. M. D. Guillain-Barré syndrome. Order lumbar puncture and nerve conduction studies. Answer: B. Myasthenia gravis. Order an acetylcholine receptor antibody test. Explanation: the patient's presentation of muscle weakness, ptosis, and difficulty swallowing, along with the worsening of symptoms throughout the day, is characteristic of myasthenia gravis, disorder of the neuromuscular junction caused by antibodies against acetylcholine receptors. The diagnostic test of choice is the acetylcholine receptor antibody test. Multiple sclerosis. A. Presents with relapsing remitting symptoms, including sensory and motor deficits, and would typically be diagnosed with an MRI of the brain and spinal cord. Amyotrophic lateral sclerosis. C. Presents with progressive motor weakness and is diagnosed with MGN clinical findings. Guillain-Barré syndrome. D. Typically presents with ascending muscle weakness and diminished reflexes, and lumbar puncture would show elevated protein levels with normal cell count. Question 20. A 72-year-old female with a history of osteoarthritis and osteoporosis presents with acute back pain after bending down to pick up a heavy object. She reports a sharp pain in the lower back that is worsened with movement. On examination, she has tenderness over the lumbar spine and limited range of motion. Her vital signs are stable, and her neurological exam is normal. What is the most likely diagnosis, and what is the initial management? A. Vertebral compression fracture. Initiate pain management with opioids and refer for spinal imaging. B. Spinal stenosis. Refer for surgical consultation and initiate physical therapy. C. Acute lumbar strain. Recommend rest, NSAIDs, and physical therapy. D. Herniated disc. Initiate physical therapy and consider MRI if symptoms persist. Answer A. Vertebral compression fracture. Initiate pain management with opioids and refer for spinal imaging. Explanation: the patient's age, history of osteoporosis, and acute onset of back pain following bending motion are suggestive of vertebral compression fracture. The initial management includes pain control, possibly with opioids if the pain is severe, and referral for spinal imaging e.g. X-ray or MRI. Spinal stenosis B typically causes gradual onset of back pain with associated leg pain and may worsen with prolonged standing or walking. Acute lumbar strain C would not typically present with history of osteoporosis or the severity of pain described here. Herniated discs D usually cause radicular pain, which is not described in this case. Question 21. A 34-year-old male presents with a 3-day history of fever, sore throat, and a red sandpaper-like rash on his neck, trunk, and arms. He has a history of recent sore throat and tonsillar exudates. On examination, he is febrile and his throat is erythematous with visible exudates. What is the most likely diagnosis, and what is the appropriate treatment? A. Streptococcal pharyngitis with scarlet fever. Initiate oral penicillin and supportive care. B. Infectious mononucleosis. Initiate corticosteroids for symptom relief. C. Viral exanthem. Provide symptomatic treatment and monitor for complications. D. Hand, foot, and mouth disease. Initiate supportive care and monitor for complications. Answer A. Streptococcal pharyngitis with scarlet fever. Initiate oral penicillin and supportive care. Explanation: the patient's presentation of fever, sore throat, and a characteristic red, sandpaper-like rash is consistent with scarlet fever, a complication of streptococcal pharyngitis. The appropriate treatment is oral penicillin to target the group, a streptococcus infection, along with supportive care. Infectious mononucleosis B cause sore throat and fever, but would typically present with lymphadenopathy and splenomegaly and not a sandpaper-like rash. Viral exanthem C can cause a rash, but is typically not associated with the sore throat and exudates seen here. Hand, foot, and mouth disease D presents with a rash on the hands, feet, and mouth, not the torso. Question 22. A 50-year-old male with a history of smoking and chronic cough presents with a 6-month history of worsening cough, hemoptysis, and unexplained weight loss. He has a hoarse voice and a history of recurrent respiratory infections. On chest X-ray, there is a mass in the left lung. What is the most likely diagnosis, and what is the next best step in management? A. Lung cancer. Initiate chemotherapy and refer for surgical consultation. B. Tuberculosis. Initiate antitubercular therapy and monitor for resolution. C. Chronic bronchitis. Initiate bronchodilators and steroids. D. Aspergillosis. Initiate antifungal therapy and monitor for improvement. Answer A. Lung cancer. Initiate chemotherapy and refer for surgical consultation. Explanation: the patient's presentation of chronic cough, hemoptysis, weight loss, and a hoarse voice, along with a mass on chest X-ray, is concerning for lung cancer. The next step is to confirm the diagnosis with further imaging, e.g. CT scan and biopsy, followed by chemotherapy or referral for surgical resection, depending on the stage. Tuberculosis B would be considered with a history of travel or exposure, but it typically presents with a chronic cough, night sweats, and weight loss. Chronic bronchitis C would present with a productive cough without weight loss or a lung mass. Aspergillosis D typically affects immunocompromised patients and presents with the fungal ball or cavitary lesions, not a lung mass. Question 23. A 28-year-old female presents with painful red and swollen joints in her hands and wrists. She reports morning stiffness lasting more than an hour. Along with fatigue, she has a family history of rheumatoid arthritis. On examination, she has symmetrical joint involvement with signs of inflammation. What is the most likely diagnosis and what is the initial treatment? A. Rheumatoid arthritis. Initiate methotrexate and refer for rheumatology consultation. B. Systemic lupus erythematosus. Initiate hydroxychloroquine and corticosteroids. C. Gout. Initiate colchicine and NSAIDs for pain relief. D. Osteoarthritis. Initiate physical therapy and pain management with acetaminophen. Answer A. Rheumatoid arthritis. Initiate methotrexate and refer for rheumatology consultation. Explanation: the patient's presentation of painful red, swollen joints, morning stiffness lasting more than an hour, and symmetrical joint involvement is characteristic of rheumatoid arthritis. RA. The initial treatment for RA includes disease-modifying antihepatic drugs, DMARDs, such as methotrexate, and referral to a rheumatologist. Management: systemic lupus erythematosus B can cause joint involvement but would also present with other systemic symptoms like a butterfly rash, photosensitivity, and renal involvement. A gout C typically presents with acute monoarticular joint pain, often in the big toe, and would not cause prolonged morning stiffness. Osteoarthritis D typically affects weight-bearing joints and presents with pain that worsens with use, rather than prolonged morning stiffness. Question 24. A 40-year-old male with a history of chronic alcohol use presents with confusion, ataxia, and nystagmus. His speech is slurred and he appears disoriented. His lab results show a low thiamine level. What is the most likely diagnosis and what is the next step in management? A. Wernicke's encephalopathy. Administer intravenous thiamine and correct electrolyte imbalances. B. Alcohol withdrawal delirium. Initiate benzodiazepines and supportive care. C. Delirium tremens. Initiate thiamine, benzodiazepines, and monitor in critical care setting. D. Hepatic encephalopathy. Refer for liver function tests and initiate lactulose therapy. Answer A. Wernicke's encephalopathy. Administer intravenous thiamine and correct electrolyte imbalances. Explanation: the patient's presentation of confusion, ataxia, nystagmus, and slurred speech, along with low thiamine levels, is highly suggestive of Wernicke's encephalopathy, complication of chronic alcohol use due to thiamine deficiency. The next step in management is to administer intravenous thiamine immediately to prevent progression to Korsakoff syndrome and correct electrolyte imbalances. Alcohol withdrawal delirium B can cause confusion and agitation, but it is not associated with the specific signs of ataxia and nystagmus. Delirium tremens C is a severe form of alcohol withdrawal, but usually presents with more pronounced autonomic instability, such as tachycardia and hypertension. Hepatic encephalopathy D can cause confusion, but is associated with liver disease and would require lactulose to reduce ammonia, not thiamine therapy. Question 25. A 45-year-old male with a history of diabetes mellitus and hypertension presents with a 2-day history of severe throbbing headache, nausea, and vomiting. He also reports blurred vision and photophobia. On examination, his blood pressure is 210 on 120 mmHg and fundoscopic exam shows papilledema. What is the most likely diagnosis and what is the next best step in management? A. Hypertensive emergency. Administer intravenous antihypertensives and monitor in the ICU. B. Migraine headache. Initiate triptans and provide supportive care. C. Subarachnoid hemorrhage. Perform a non-contrast CT scan of the head. D. Acute angle closure glaucoma. Administer topical ophthalmic agents and refer to an ophthalmologist. Answer A. Hypertensive emergency. Administer intravenous antihypertensives and monitor in the ICU. Explanation. Is patient's presentation of severe headache, nausea, vomiting, blurred vision, photophobia, and elevated blood pressure with papilledema suggests hypertensive emergency. In hypertensive emergency, the blood pressure is significantly elevated and is associated with evidence of end organ damage, such as the papilledema seen in this patient. Step in management is to administer intravenous antihypertensive medications, e.g. labetalol, nicardipine, in controlled manner to reduce the blood pressure and prevent further complications. Migraine headaches, B, can cause nausea and vomiting but would not be associated with significantly elevated blood pressure or papilledema. Subarachnoid hemorrhage, C, may present with headache, but it typically comes on suddenly and is more severe. Non-contrast CT scan would help confirm the diagnosis. Acute angle closure glaucoma, D, presents with eye pain and visual changes, but would not typically cause headache with nausea and vomiting in the absence of visual disturbances. Question 26. A 70-year-old male presents with progressive difficulty swallowing, hoarseness, and a persistent cough for the past few months. He has a 40-year history of smoking. On examination, he has enlarged cervical lymph nodes and a firm, non-tender mass in the right side of his neck. What is the most likely diagnosis and what is the next best step in management? A. Laryngeal cancer. Refer for biopsy and imaging studies. B. Thyroid cancer. Order an ultrasound of the neck and refer to an endocrinologist. C. Esophageal cancer. Order an upper gastrointestinal series and refer for endoscopy. D. Tuberculosis. Initiate antitubercular therapy and obtain a chest X-ray. Answer A. Laryngeal cancer. Refer for biopsy and imaging studies. Explanation. Is patient's presentation of progressive difficulty swallowing, hoarseness, and persistent cough, along with history of smoking and enlarged cervical lymph nodes, is highly suggestive of laryngeal cancer. The next step in management is to refer the patient for biopsy and imaging studies such as ET or MRI to assess the extent of the disease and determine the appropriate treatment. Thyroid cancer, B, can cause neck mass but is more commonly associated with history of thyroid nodule. Esophageal cancer, C, could cause difficulty swallowing but it would not typically present with hoarseness or neck mass. Tuberculosis, D, can cause lymphadenopathy but is less likely given the chronicity of the symptoms and the presence of neck mass. Question 27. A 60-year-old female presents with gradual onset of shortness of breath, especially with exertion. She has a history of rheumatoid arthritis and has been on long-term methotrexate therapy. On examination, she has crackles at the lung bases and digital clubbing. A chest X-ray reveals bilateral interstitial markings. What is the most likely diagnosis and what is the next best step in management? A. Rheumatoid lung disease. Refer for pulmonary function tests and consider corticosteroid therapy. B. A pulmonary embolism. Perform a pulmonary angiogram. C. A chronic obstructive pulmonary disease, COPD. Initiate bronchodilators and pulmonary rehabilitation. D. Idiopathic pulmonary fibrosis. Refer for high-resolution CT scan and consider lung biopsy. Answer A. Rheumatoid lung disease. Refer for pulmonary function tests and consider corticosteroid therapy. Explanation. The patient's gradual onset of shortness of breath, crackles at the lung bases, and interstitial lung markings on chest X-ray in the context of long-term methotrexate use and history of rheumatoid arthritis is suggestive of rheumatoid lung disease. The next step in management is to refer for pulmonary function tests to assess the degree of lung involvement and consider corticosteroid therapy to manage inflammation. Pulmonary embolism, B, it can cause shortness of breath but would typically present acutely and is not associated with interstitial lung markings. COP, C, presents with productive cough and history of smoking, not rheumatoid arthritis or methotrexate use. Idiopathic pulmonary fibrosis, D, presents with progressive dyspnea and interstitial lung markings but is not typically associated with rheumatoid arthritis or methotrexate therapy. Question 20. A 35-year-old female presents with a 1-week history of fatigue, low-grade fever, sore throat, and a swollen, tender neck. She also reports a recent history of contact with a family member who has been ill with a viral illness. On examination, she has bilateral tender anterior cervical lymphadenopathy, tonsillar exudates, and a red, inflamed throat. What is the most likely diagnosis and what is the next best step in management? A. Infectious mononucleosis. Perform a monospot test and provide supportive care. B. Acute bacterial pharyngitis. Initiate oral antibiotics and refer for throat culture. C. Cytomegalovirus infection. Order PCR testing for CMV and initiate antivirals. D. Streptococcal pharyngitis. Initiate oral antibiotics and perform a rapid strep test. Answer A. Infectious mononucleosis to perform a monospot test and provide supportive care. Explanation: the patient's presentation of fever, sore throat, and swollen lymph nodes, along with recent history of exposure to viral illness, is most consistent with infectious mononucleosis caused by Epstein-Barr virus. The next step in management is to perform monospot tests to confirm the diagnosis and provide supportive care, as most resolve spontaneously. Acute bacterial pharyngitis B typically presents with higher fever and does not usually cause the lymphadenopathy or exudate seen in this patient. Cytomegalovirus C infection can cause similar symptoms but is less likely in healthy, immunocompetent individual and is more commonly diagnosed by PCR testing. Streptococcal pharyngitis D is unlikely given the lymphadenopathy and viral symptoms. Question 29. A 32-year-old male presents with pain, swelling, and erythema over the right knee after a sports injury. He is unable to bear weight on the affected leg. On examination, there is significant effusion and he is unable to extend the knee fully. What is the most likely diagnosis and what is the initial management? A. Meniscal tear. Refer for MRI and initiate ice compression and elevation. B. Anterior cruciate ligament ankle tear. Refer for MRI and surgical evaluation. C. Patellar dislocation. Perform a reduction and apply a knee brace. D. Osteoarthritis and recommend rest, NSAIDs and physical therapy. Answer B. Anterior cruciate ligament ankle tear. Refer for MRI and surgical evaluation. Explanation: this patient's presentation of knee pain, swelling, and inability to extend the knee fully after sports injury is most consistent with an ankle tear, especially given the mechanism of injury. Initial management includes rest, ice compression, and elevation to reduce swelling, along with referral for MRI to confirm the diagnosis and surgical evaluation. Meniscal tears can cause knee pain and swelling but would not typically result in the inability to extend the knee. Patellar dislocation C can cause knee pain and swelling but would typically present with an obvious deformity that can be reduced. Osteoarthritis D would not be expected in 32-year-old without history of chronic knee problems. Question 30. A 55-year-old female presents with a 2-month history of progressive difficulty walking, particularly with balance. She reports feeling lightheaded and having occasional double vision. She has a history of hypertension and diabetes. Neurological examination reveals a positive Romberg sign, diminished vibration sense in the lower extremities, and bilateral lower extremity weakness. What is the most likely diagnosis and what? Next best step in management? A. Multiple sclerosis. Perform an MRI of the brain and spinal cord with contrast. B. Vitamin B deficiency. The order serum vitamin B and methylmalonic acid levels. C. Parkinson's disease. Refer for a neurologic evaluation and initiate dopaminergic therapy. D. Acute stroke. Perform a knee of the head without contrast and initiate thrombolytic therapy if applicable. Answer B. Vitamin B deficiency. Order serum vitamin B and methylmalonic acid levels. Explanation: this patient's progressive difficulty walking, balance problems, lightheadedness, and neurological signs, positive Romberg, diminished vibration sense, and lower extremity weakness are consistent with subacute combined degeneration condition caused by vitamin B deficiency. The next best step is to order serum vitamin B, methylmalonic acid levels to confirm the diagnosis. Multiple sclerosis could present with balance problems and neurological signs, but typically has relapsing remitting episodes and would be diagnosed with an MRI showing lesions in the central nervous system. Parkinson's disease C presents with tremors, bradykinesia, and rigidity, rather than balance issues related to sensory loss. Acute stroke D would present with sudden onset symptoms, unilateral weakness or speech deficits, not gradual symptoms over weeks or months.